1, 2,
And
Patients here.
somebody male, female,
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the property.
45 minutes of CPR and no return of circulation. Okay.
Oh.
You know, usually when we talk about a medical diagnosis, there's this expectation of precision. It's like engineering. You break your arm, the x-ray shows that jagged white line, and the clinician just points at it and says, you know, there it is. There's the source of your pain.
Right, it is binary. And that's incredibly comforting for both the patient and the provider.
Yeah.
I mean, we like things to be visible, to be categorized, and to have a straightforward mechanical fix. You put a cast on it, the bone knits, problem solved.
Broken or not broken, it's clean. But then you step into the world of psychiatric nursing and, well, suddenly that x-ray machine is just broken. We're looking at a diagnostic landscape where the mind and the body completely cross wires.
Yeah, they really do.
We're talking about situations where severe stress, psychological trauma, and unexpressed emotions manifest as very real, very distressing physical symptoms. So welcome to this deep dive. If you are an ambitious nursing student or a clinician stepping onto the floor, we are here to be your elite psychiatric nursing mentors.
Absolutely. Our mission today is to decode the highest yield 20% of the material that is going to unlock 80% of your understanding for NCLEX style exams, and most importantly, for safe patient care.
Okay, let's unpack this because it's wild. How can someone be physically paralyzed, like confined to a wheelchair, when there is absolutely nothing neurologically wrong with their spine or their brain?
It is one of the most profound mysteries in medicine, honestly. And this is where we have to establish a foundation if we are going to navigate these diagnostic muddy waters.
Right.
To understand how the brain can literally switch off motor function without physiological damage, we have to establish the absolute baseline rules that govern all somatic symptom illnesses.
Because if you don't grasp the core mechanics here, you will just get bogged down in the clinical fluff.
Exactly. You'll miss the priority safety questions, and you will inevitably struggle with patient care.
So let's start with the absolute foundation. What is the core rule that governs everything we are looking at today?
The absolute core concept, the lens through which every somatic illness must be viewed, is the difference between conscious and unconscious behavior.
Okay. Conscious versus unconscious.
Yes. Clients with somatic symptom illnesses are not making it up. The symptoms are not under their conscious control. They're genuinely experiencing the agonizing pain, the gastrointestinal distress, the blindness, or the paralysis.
I really want to emphasize this because I think it's where the majority of the stigma in healthcare comes from. When a nurse or a doctor looks at a test result and sees that the spine is perfectly intact or, the cardiac enzymes are completely normal, the immediate human reaction is to think, well, they must be faking it.
Oh, absolutely. It feels like a manipulation.
Right. But the psychiatric literature is explicit. The distress is real to them. The brain has created a physical reality out of psychological distress.
And that leads directly to the most critical safety risk you will encounter as a nurse. The golden rule is this. You must always rule out a legitimate medical condition first. You can never, ever dismiss a new physical complaint just because the patient has a documented history of a somatic disorder.
Let's think about this like a car's check engine light. Let's say your car has a faulty sensor, right? The check engine light comes on all the time for absolutely no reason. It's a known glitch in the dashboard wiring.
Right, you're used to it.
But if that light comes on tomorrow morning, you can't just assume it's the glitch again. You still have to open the hood and check the engine, because what if today is the day the transmission actually drops out?
That is a perfect analogy. If a patient with a known, say, 10-year history of severe somatic symptom disorder complains of sudden crushing chest pain radiating to their jaw, your priority nursing assessment is an EKG, oxygen, and cardiac enzymes.
You treat it as an acute MI until proven otherwise.
Exactly. The fact that they have somatized 50 times in the past does not make them immune to a heart attack today. If you assume it's just their psychiatric condition acting up and you skip the physical assessment, that is a catastrophic failure of clinical judgment.
So we open the hood every time. But clinically, that creates a paradox, doesn't it? I mean, if we treat every single complaint like an emergency, aren't we going to end up giving them heavy-duty pain meds for something that originates in the mind?
And that is the exact trap many providers fall into, and it introduces our must-know medication principle for exams. For these patients, you must aggressively avoid prescribing or administering narcotic analgesics
Because they're in pain, but
because they're experiencing real, unremitting pain. Yes, the human instinct is to treat it with powerful opioids. But the root cause of the pain is psychological, not structural.
so the narcotics won't actually resolve the issue. They just sort of mask the emotional distress temporarily, right? While introducing a massive risk of physical dependence.
The risk of substance misuse is astronomically high. These patients will often end up doctor shopping, moving from clinic to clinic, looking for someone who will finally validate their pain with a narcotic prescription.
Wow.
And once that physical dependence takes hold, you have severely compounded their psychiatric illness with this substance use disorder.
But wait, if it is all unconscious, how do we distinguish it from someone who is actively faking it? Like someone who is faking a back injury to get out of work or get a massive payout from a lawsuit. How does a nurse look at a patient and know if it's an unconscious somatic disorder or conscious manipulation?
Well, the short answer relies on understanding the psychological payoff, which we call primary and secondary gains, and whether the patient can magically turn the symptoms off when they get what they want.
Okay, the payoff.
But to truly differentiate them, we first have to understand the engine driving the unconscious symptoms. We have to look at the pathophysiology. We need to know how emotional pain mutates into physical pain.
Let's get into the mechanics of that. What is actually happening in the brain and the body to cause this mutation?
The core psychological mechanism is a concept called internalization. Psychosocial theorists emphasize that people with somatic symptom illnesses, they do not express stress, anxiety, or frustration outwardly.
They bottle it up.
Exactly. Instead of talking about their feelings, they keep them inside. The mind then takes that internalized emotional energy, which has nowhere to go, and converts it into physical symptoms. This process is called somatization.
Somatization, the transference of mental experiences into bodily symptoms. And again, this is an unconscious defense mechanism, but why can't they just talk about it? I mean, if a patient is overwhelmed by a toxic marriage or a failing career, why can't they just say, I'm really stressed?
Because for many of these clients, they literally lack the neurological or psychological vocabulary for it. And this brings us to a crucial term you need to know: alexithymia.
Alexithymia.
Yes, alexithymia is the inability to identify and describe emotions. It is not a stubborn refusal to talk about feelings. It is an actual deficit in emotional processing.
Oh, interesting.
If you ask them how they feel about a devastating life event, they won't say they are sad or grieving or angry. They might say, my stomach has been in knots and my back is killing me. They experience emotional distress purely as physical sensation.
It's like their brain's translation software is completely broken. Like the input is profound sadness, but the output on the screen is severe backache.
Exactly. And there are biologic theories that explain the physiological side of this. It's not just a psychological metaphor. There are physical changes in how their nervous system processes information. This is where visceral hypersensitivity comes into play.
Visceral hypersensitivity. Break down the biology of that for us. How does the nervous system actually amplify these signals?
So our bodies are constantly making noise: digestion, peristalsis, minor muscle tension, the expanding and contracting of blood vessels.
Right.
A healthy autonomic nervous system filters that out. The brain effectively puts a gate down and says, we don't need to pay attention to the intestines moving food. But for a patient with visceral hypersensitivity, there's a failure of that sensory inhibition. The gate is left wide open.
So they feel a normal bodily sensation and their brain just amplifies it.
Yeah, and acute psychological stress actually induces this hypersensitivity. When the sympathetic nervous system is in overdrive from unexpressed anxiety, it lowers the threshold for pain receptors. So they feel normal sensations as intense, noxious, disturbing pain.
Wow.
The pain is biologically real, but the origin is a hypersensitive nervous system responding to psychological stress, not a broken bone or a tumor.
So the internal volume knob is turned all the way up, and the filter is just broken. This brings up some really interesting demographic and cultural risk factors from the source material. The data shows that somatic symptom illnesses are significantly more common in females. Why is that? What are the psychosocial variables driving that demographic split?
There are several theories. First, there are deeply ingrained societal norms. Historically, and even in many cultures today, men are conditioned to be stoic. which often manifests as suppressing physical complaints as well.
Right, the tough it out mentality.
Conversely, it has historically been more socially acceptable for women to seek medical care for ailments. But beyond modern sociology, there's a very dark historical pie here. The word hysteria, which was the ancient catch-all medical term for these somatic disorders, comes from hystera, the Greek word for uterus.
Wait, really?
Yes, ancient medical theorists bizarrely believed that unexplained pains, paralysis, and anxiety were caused by a wandering uterus moving around the body and putting pressure on other organs.
It is wild to think that for centuries, the highest levels of medical science believed the uterus was just floating around causing paralysis.
It sounds absurd now, but that historical bias created a long-standing legacy of dismissing female pain. On a much more serious and modern note, trauma is a massive risk factor. There's a strong correlation between childhood trauma, particularly childhood sexual abuse, and the development of somatization later in life.
That makes sense.
Because sexual abuse unfortunately happens at higher rates to female youth, this skews the demographics heavily.
The body holds onto the trauma when the mind cannot safely process it, and it manifests as physical illness decades later. Here's where the cultural aspect gets incredibly fascinating to me, though. The sources talk about how different cultures manifest this mind-body crossing in completely different ways.
Yes, the cultural syndromes.
If the underlying mechanism is the same, internalization and visceral hypersensitivity, why do the symptoms look so different depending on where you live?
Because culture provides the language for distress. The cultural expressions of somatization are incredible examples of how our environment shapes our symptoms. In Western cultures, the acceptable language of illness is often chronic fatigue, back pain, or gastrointestinal issues.
Right. Those are culturally validated reasons to seek medical help and be excused from obligations.
Exactly. But if you look globally, the somatic presentation adapts to local beliefs.
The sources mention Koro in Southeast Asia. This is a condition where an individual has an intense, terrifying belief that their genitals are shrinking and retracting into their abdomen, and that this retraction will ultimately cause them to die.
It's a profound fear.
The anxiety is profound, and the physical sensation of retraction is entirely real to them, even though physically nothing is changing.
And we see falling out in the southern United States and the Caribbean. This is characterized by a sudden collapse. The person cannot see or move, though their eyes might be open, and they can hear what is happening around them.
It looks like a severe neurological event.
But it is a somatic response to acute stress.
There is also hwabyung in Korea, which literally translates to fire illness or anger syndrome. It is directly attributed to the suppression of anger over a long period, typically familial or marital conflict that cannot be culturally expressed.
And how does it manifest?
It manifests physically as insomnia, panic, indigestion, and generalized aches. The core engine somatization is identical across the globe, but the flavor of the symptoms is entirely dictated by what the surrounding culture deems a valid expression of distress. But, if their brain is just misinterpreting normal body signals due to stress and creating these terrifying, debilitating symptoms, how does the symptom actually help them? If the brain is deploying a defense mechanism, what is the payoff? Why does the unconscious mind choose paralysis or severe pain over just dealing with a bad marriage or a stressful job?
That question brings us to the very engine of the illness. To understand the payoff and to answer NCLEX questions on this topic, you have to master two massive concepts: primary game and secondary game.
Okay, primary and secondary.
This is the operant conditioning loop that keeps the illness alive.
Let's break down primary gain first. What is the internal payoff for the patient?
Primary gain is the direct internal psychological benefit that being sick provides. The physical symptom provides immediate relief from the underlying anxiety, conflict, or distress.
How so?
By focusing all their mental energy on the physical pain or the sudden blindness, the patient is completely distracted from the psychological trauma or the unbearable life situation. The physical symptom essentially acts as a pressure release valve for the mind.
Okay, so let's say I'm facing a brutal divorce. The reality of it is so emotionally devastating that my mind literally cannot process it. If my mind suddenly develops paralyzing, agonizing back pain, I am no longer thinking about the divorce.
Right, you're focused on the pain.
I am entirely consumed by navigating the healthcare system for my back pain. The unbearable anxiety about the divorce is relieved. That emotional relief is the primary gain.
That is the exact mechanism. The psychological threat was neutralized by creating a physical emergency. But the cycle doesn't stop there. Then we introduce secondary gain.
And what's that?
This is the external benefit. These are the tangible, real-world benefits received from others because the person is sick.
Give me some concrete examples of secondary gain in a clinical or home setting.
It could be attention from family members who usually ignore them. It could be comfort measures, getting a back rub, having someone bring you meals in bed, or, incredibly commonly, is being excused from stressful responsibilities.
Oh, like not having to go to work.
Goat.
Exactly. You don't have to go to the job you hate. You don't have to take that difficult college exam. You don't have to engage in social events that cause you severe social anxiety.
So the patient's unconscious mind learns a very powerful, dangerous lesson. It learns that they need to be sick to get their emotional needs met, to get love and attention, and to avoid things they just can't handle.
It is classic operant conditioning. The behavior, the physical symptom, is rewarded by both internal anxiety relief and external comfort and avoidance.
And so they keep doing it.
Therefore, the behavior is strongly reinforced and becomes chronic. The brain says, this works perfectly, we will do this every time we feel stressed. This dictates our nursing interventions later on. If we want the patient to recover, our treatment must focus heavily on minimizing those secondary gains. We have to systematically stop rewarding the symptom.
We will dive deep into exactly how nurses do that without seeming cruel in a few minutes. But first, let's categorize the specific diagnoses. We understand the engine, now internalization, somatization, primary and secondary gains. Let's look at the specific disorders this engine drives, the diagnosis criteria, and the expected findings you will see on a clinical floor.
Okay, there are three main diagnoses in this category that you must be able to differentiate. Let's start with the umbrella term, Somatic Symptom Disorder.
What's the definition there?
This is characterized by one or more physical symptoms that have no evident medical explanation. But the crucial diagnostic criterion is not just the presence of the symptom, it's the intense psychological reaction to it.
Right. The sources state they spend a massive, disproportionate amount of time and energy focused on their health concerns. They experience significant distress that just consumes their daily life.
For expected findings, you are looking for a decades-long chronic history. These patients have medical charts that look like encyclopedias. They will give you lengthy, colorful, highly exaggerated accounts of previous medical problems.
And they've probably seen 1 million doctors.
Yes, they have usually undergone numerous invasive diagnostic tests and often completely unnecessary exploratory surgeries.
And what is their demeanor usually like with the nursing staff?
They are usually very frustrated and demanding. A classic behavioral finding is doctor shopping. They go from clinic to clinic, specialist to specialist, searching for someone who will finally diagnose their mystery illness.
Searching for an answer that doesn't exist physically.
Exactly. They tend to be pessimistic and will frequently express anger at the medical community, claiming that all the doctors and nurses are incompetent because no one can find the physical root of their problem.
Okay, so that's somatic symptom disorder. Chronic, painful, obsessed with the symptoms, frustrated with the healthcare system. Now, let's pivot to the one that I find the most neurologically baffling. Functional neurologic symptom disorder. This is the one that used to be called conversion disorder, right?
Correct. The DSM-5 updated the name to Functional Neurologic Symptom Disorder. Though conversion disorder is still widely used in older texts and exams, this involves unexplained, usually sudden deficits in sensory or motor function.
We're talking about symptoms that strongly suggest a major neurological stroke or disorder, blindness, deafness, paralysis of a limb, or the sudden inability to speak.
Yes, profound functional impairment. And it usually presents suddenly, typically between the ages of 10 and 35. However, there is a bizarre hallmark behavioral finding associated with this disorder that is highly testable. It is a French term, la belle indifférence.
La belle indifférence, the beautiful indifference. What does that actually look like when you walk into a patient's room?
Imagine walking into the room of a 20-year-old college student. They woke up this morning completely blind.
I would be freaking out.
You or I would be in absolute hysterics. We would be panicking, hitting the call light, crying, demanding a neurologist. A patient with functional neurologic symptom disorder and la belle indifférence will tell you they are blind with the same flat emotional affect as if they were telling you what they had for lunch.
Seriously?
There is a striking, almost eerie lack of concern or distress about their severe, sudden functional loss.
But how is that humanly possible? How does the brain not panic when it loses vision?
This goes right back to primary gain. The physical symptom, the sudden blindness, was created by the mind to relieve an overwhelming, unbearable psychological conflict.
Ah, right.
Perhaps they were facing a situation they literally could not bear to see or participate in. The blindness successfully eliminated the anxiety of that situation.
Oh.
Therefore, the patient's actually deeply relaxed.
Yeah.
The defense mechanism worked flawlessly. They are physically impaired, but psychologically relieved.
The mind's ability to compartmentalize and protect itself is terrifyingly powerful. Okay, what is the third major disorder?
Illness anxiety disorder, formerly known as hypochondriasis. This presentation is distinctly different from the first two.
How so?
In somatic symptom disorder, the patient is focused on the severe pain or distress they are having right now. In illness anxiety disorder, the preoccupation is with the intense fear that one already has a serious disease, or the fear that they will get a serious disease, despite having minimal to no actual physical symptoms.
It's disease conviction versus disease phobia.
Exactly. They misinterpret normal bodily sensations as absolute proof of impending doom. A minor muscle twitch is definitely ALS. A mild headache is undeniably a glioblastoma.
It's a spiral.
They become trapped in a somatic amplification loop, where their anxiety makes them hyper-focus on a body part, which increases the sensation in that body part, which validates their anxiety.
What are the expected findings for a patient with illness anxiety disorder?
You will see a fascinating obsessive focus on medical information. These are the patients who come to the clinic with a massive binder full of WebMD printouts and medical journal abstracts.
They've done their research.
Yes. They have unrealistic fears of infection or contamination. You will often see ritualistic behaviors like obsessive checking of their pulse, blood pressure, or exaggerated, highly specific bowel routines. They also heavily overuse over-the-counter medications and home remedies in an attempt to stave off the dreaded disease.
Stephen, I'm trying to organize these three in my head for an exam. Let me try an analogy based on a mild stomachache.
Let's hear it.
Somatic symptom disorder is the patient saying, I have this terrible agonizing stomach pain right now. It's ruining my life, and you doctors are useless for not fixing it. Illness anxiety disorder is the patient saying, I'm terrified this mild stomach ache means I have stage 4 pancreatic cancer. Let me show you my research. And functional neurologic symptom disorder is a patient saying, I suddenly can't move my legs or feel my stomach, but whatever, it's fine. What time is physical therapy?
That is an excellent framework that perfectly encapsulates the core differences in presentation, motivation, and reaction. Keep that in mind for any clinical scenario.
All right, so those three disorders, somatic symptom, functional neurologic, and illness anxiety, are all completely unconscious. The patient is not faking it. The symptoms are real to them. But what happens when a patient is doing it on purpose? Because we know that happens in the real world.
It absolutely does.
This brings us to the distractors, factitious disorders and malingering. I know exams love to test the ability to differentiate these conscious behaviors from the unconscious disorders.
They love to test it. Let's start with malingering. The core problem here is the intentional, willful production of false or grossly exaggerated physical or psychological symptoms. But the key to identifying it is the motivation. Malingering is motivated purely by external, tangible incentives.
External incentives like what?
Avoiding work, avoiding military deployment, evading criminal prosecution, obtaining financial compensation in a lawsuit, or trying to obtain prescription drugs. The malingerer has a specific real-world goal.
So if someone gets into a tiny fender bender and they intentionally fake severe whiplash because they want a $10,000 insurance payout, that's malingering.
Correct. And the most distinguishing clinical feature of malingering is that they can miraculously stop the symptoms as soon as they get what they want. Once the insurance check clears, the neck brace immediately goes in the trash. The illness served its purpose.
Okay, so malingering is faking it for a tangible reward. How is factitious disorder different? Because they are intentionally faking or causing symptoms too, right?
Yes. In factitious disorder, which was historically known as Munchausen syndrome, the production of symptoms is also entirely intentional. They might inject themselves with insulin to cause severe hypoglycemia, they might ingest blood thinners to cause internal bleeding, or they might put feces in their own IV line to cause sepsis.
Oh my God.
But the motivation is entirely different from malingering. There is no financial, legal, or occupational reward. The sole motivation is internal, to gain attention, sympathy, and to assume the sick role.
They just want the emotional comfort of being a patient. They want the doctors to fuss over them, the nurses to care for them, the family to worry about them.
The psychological need for that specific type of attention is so profound that they will inflict life-threatening harm on themselves to get it. And this leads us to one of the most critical safety, ethical, and legal concepts in nursing: factitious disorder imposed on another, commonly known as Munchausen by proxy.
This is the one that makes every healthcare professional's blood run cold.
It is a massive nursing safety red flag. This occurs when a person intentionally inflicts illness or injury on someone else, usually a vulnerable dependent child, an elderly parent, or even a patient, in order to gain the attention of medical personnel for themselves, or to play the role of the heroic caregiver.
The source material gives a terrifying example. A nurse who intentionally administers excess 5E potassium to a client, triggering cardiac arrest, just so they can swoop in, perform flawless CPR, and look like a hero to their colleagues and the family.
It is chilling, and unfortunately it happens. These individuals are very often highly familiar with the medical profession. They know how to manipulate monitors, how to alter pediatric lab results, how to administer dangerous doses of medications without leaving immediate evidence.
So, if a nurse is working in a pediatric unit and they start noticing discrepancies like a child only has seizures when the mother is alone in the room, or the child's lab results make absolutely no physiological sense based on their presentation, what is the nurse's immediate role?
This immediately moves out of the realm of psychiatric treatment and into the legal system. People who injure children or patients this way are committing a criminal act of abuse.
Right.
As a nurse, you are a mandatory reporter. If you suspect factitious disorder imposed on another, especially involving child abuse or elder abuse, you do not try to therapeutically confront the perpetrator. You must ensure the immediate physical safety of the patient, and you must report it immediately to your charge nurse, the attending physician, and the appropriate authorities according to your facility's policy and state law. There is no gray area here.
That is a crucial distinction. Malingering is for a prize. Factitious is for the sick role. And if it's forced on a dependent, it is a crime requiring immediate intervention. Okay, we've covered the diagnoses and the distractors. Now we need to transition from diagnosis to action. What does the nurse actually do when faced with these patients on the floor?
We circle back to the absolute #1 priority, which we discussed in the Golden Rules. You must assess physical health status thoroughly for underlying pathology.
Check the engine light every time.
Yes. If your patient with illness anxiety disorder complains of new sudden shortness of breath, you do not just say, take some deep breaths, it's just your anxiety acting up again. You get an oxygen saturation, you listen to their lung fields, you check their vital signs, and you notify the provider. Do not assume complaints are psychosomatic until medical causes are ruled out.
What are some specific physical assessments for the different disorders? For instance, the functional neurologic patients who are completely paralyzed. What are we assessing there if we know their spine is fine?
For those patients, you must aggressively assess for disuse syndrome. If a patient believes they are paralyzed and they sit motionless in a wheelchair or lie in bed for 3 months, their muscles don't know it's a psychiatric issue.
Right, the muscles will just atrophy.
Exactly. The muscles will begin to weaken and undergo severe atrophy from lack of use. You have to monitor their skin integrity for pressure ulcers. You must perform passive range of motion exercises to prevent contractures, and you must assess for deep vein thrombosis due to immobility.
What about assessing their medication history? You mentioned earlier that they doctor shop.
That is a massive nursing priority. You must comprehensively assess their substance use and medication history upon admission. Because they jump from provider to provider, they are often on multiple, overlapping prescriptions from different doctors who don't share records.
That sounds dangerous.
It is. They're at an incredibly high risk for reliance on pain medications or central nervous system depressants, particularly anxiolytics like benzodiazepines.
Which means they are at a massive risk for withdrawal.
Exactly. If they're admitted to your psychiatric unit and suddenly cut off from the 6 different providers prescribing them Ativan or Xanax, their GABA receptors are completely downregulated. You need to be monitoring them closely for severe withdrawal symptoms, including seizures and delirium tremens, which are life-threatening medical emergencies.
Okay, I have a major mechanistic question here. You just said we have to do a full medical workup every single time they have a new complaint. But earlier, you said we have to minimize secondary gains, meaning we shouldn't reward the behavior with extra attention. Doesn't doing an EKG and drawing labs every time they complain just feed the illness? How do we balance patient safety with not feeding the psychological monster?
That is the hardest tightrope to walk in psychiatric nursing, and it is exactly what exams will test you on. The way you balance medical safety and psychiatric boundary setting is through a highly structured assessment routine and strict milieu management.
Walk me through it. Let's actually game this out. How do I do this on the floor?
When the patient voices a new physical complaint, you assess it professionally and efficiently. You refer them to the medical staff. Once that specific complaint has been medically evaluated and cleared, meaning the provider has reviewed the EKG, the labs are negative, and there's no acute physical danger, you systematically and completely withdraw attention from that physical symptom.
Withdraw attention? That sounds incredibly harsh. How do you do that without seeming cruel or neglectful?
You do it with neutral professionalism. You don't ignore the patient, you ignore the symptom. You might say, the doctor has reviewed your tests and ruled out a cardiac issue. Your heart is healthy. Now, I am here to help you get ready for morning group therapy.
And if they keep pushing it?
If they continue to talk about their chest pain, you do not engage with the symptom. You might say, we have thoroughly addressed your chest. I will not be discussing it further right now, but I would love to hear about how you slept last night.
You literally starve the symptom of oxygen.
You are minimizing the secondary gain. They learn that the symptom no longer buys them endless conversation and concern, which leads to the next vital intervention. Do not give special privileges or excuse them from responsibilities.
So if they say, my legs hurt way too much to walk down to the dining room today, can I just eat my meal in my bed?
The answer is a firm, professional no. You make your expectations clear. You expect them to participate in unit activities, complete their self-care, and eat in the dining room, exactly like every other patient.
Because giving in is a reward.
Yes, granting special privileges is a massive secondary game. It reinforces the unconscious idea that being sick gets them out of the hard work of daily living and psychiatric recovery.
Let's escalate the role play. What if they just won't stop talking about it? What if every single time you walk in the room to check their vitals or give meds, they start listing their 30 different ailments and demanding you look at a new rash?
You implement strict time limits. This is a very effective, highly testable strategy on exams. You allow a specific, limited time, for example, 5 minutes per hour, to discuss physical complaints with one designated staff member.
5 minutes. That's it.
That's it. You tell the patient, for the next 5 minutes, you can tell me everything about your physical symptoms. I will listen carefully. And you do. You give them your undivided attention.
And when the timer goes off?
But when the 5 minutes is up, you say, our time for discussing physical complaints is over. For the rest of the hour, we will only focus on other issues. If they insist on talking about symptoms, you withdraw your attention entirely. You leave the room if necessary, telling them you will return when they are ready to discuss other topics.
It's basically extinction training. You are teaching their nervous system that the somatic symptom no longer yields the reward of endless engagement. But wait, if somatization is their only way of dealing with stress, and we block it with these time limits and boundaries, aren't they going to explode? What do we give them to replace the symptom?
Exactly. We can't just strip away their only coping mechanism without giving them new tools, or they will experience a massive anxiety spike. That is where teaching structured coping strategies comes in. We teach two distinct categories: emotion-focused coping and problem-focused coping.
Let's start with emotion-focused coping. How does that help?
Emotion-focused coping helps them relax the nervous system and reduce the physical sensation of stress, which combats that visceral hypersensitivity. We teach them progressive muscle relaxation, deep breathing exercises, and guided imagery.
To calm the actual body down.
Yes. We educate them that these techniques won't magically cure their pain instantly, but it will help them manage the intensity and dial down the sympathetic nervous system overdrive.
And what about problem-focused coping?
That is about addressing the root cause of the internalized stress. It involves teaching basic problem-solving processes, identifying the actual psychological problem, brainstorming alternatives, weighing pros and cons.
So dealing with the actual issue instead of making a symptom out of it.
Precisely. It heavily includes role-playing social interactions. If their anxiety spikes to the point of severe nausea because they don't know how to set boundaries with an abusive family member, you sit down and role-play that conversation with them so they feel prepared and don't have to rely on sickness to avoid the conflict.
As I'm listening to this, I have a very real observation. Managing these patients sounds incredibly, profoundly frustrating for the nurse. You are dealing with someone who refuses to believe there is nothing physically wrong, who constantly complains, who demands tests, and who progresses at a glacial pace.
Your observation touches on a major self-awareness issue highlighted in the source material. It is vital for your own mental health and professional longevity to recognize the risk of countertransference. These patients are often angry. They are highly critical of the inadequate care they perceive they're receiving.
I'm sure they let you know it too.
Oh, they will tell you to your face that you are a terrible nurse because you aren't fixing their pain.
How does a nurse not take that personally? How do you not snap at them and say there is nothing wrong with you?
You have to constantly reframe the behavior in your own mind. You must remind yourself that their coping mechanism is deeply ingrained. They've been doing this for years, maybe decades. Their brain literally knows no other way to survive stress.
Progress is going to be slow.
Progress will be slow and painstaking. The nurse must absolutely not respond with anger, sarcasm, or judgment. You have to be realistic about the small successes. Acceptance and a non-judgmental attitude are clinically required, or you will burn out and provide subpar care.
That is such a crucial point. It's not about you, it's about their broken defense mechanism. Okay, so knowing what to do is one thing, but exactly what to say, the actual words that come out of your mouth, is where students pass or fail their clinicals and their NCLEX exams. Let's move into therapeutic communication.
This is where you score your points on exams. Let's start with what not to say, because these are always the distractor answers on multiple choice tests. Never, ever argue with the patient about their somatic complaints.
So don't say, look at the MRI, your back is completely fine, get out of bed.
Never. Never confront them and say, it's all in your head or these symptoms aren't real. Remember the foundational rule. The symptoms are real to them.
If you say it's fake, you lose them.
If you invalidate their physical reality, you destroy the therapeutic relationship immediately. They will just view you as another incompetent, uncaring provider who doesn't understand them, and their anxiety will actually increase.
Okay, so if I can't agree with them that they have a mystery disease, because that feeds the delusion, but I can't tell them it's in their head, because that destroys trust, what is the magical formula? What do I say?
The exam-winning dialogue formula is validation plus collaboration. You validate the difficulty of their experience, and then you immediately pivot to encourage collaborative action.
Give me a concrete example. Let's role play again. I'm the patient. I really wish I could walk outside and get some fresh air with the group, but I feel so terrible, my legs are so weak, I just can't do it.
A terrible non-therapeutic response would be, your legs are fine, the doctor cleared you, get up. A therapeutic high-yield response is, I know this is difficult for you, but some exercise is essential. It will be a short walk.
That's brilliant. Validation, I know this is difficult for you, plus collaboration. Some exercise is essential, it will be a short walk. You didn't agree the legs were broken, but you acknowledged the struggle. Let's try another one. I'm the patient. I just can't eat anything on this tray. I have no appetite at all. My stomach hurts way too much.
Okay, follow the formula. Validation. I know you don't feel well right now. Collaboration. But it is important to begin eating. If you begin to eat just a few bites, you may start to feel better.
You validated the discomfort and you pushed them toward the expected behavior without giving them an out to skip the meal. What about when they demand constant reassurance? Like, did the doctor check the labs again? Are you sure it's not cancer? I need you to check my chart again.
This is where you practice shifting the focus. You use minimal objective reassurance. You state the clinical fact exactly once. Your tests show no lesions. And then you immediately pivot to exploring their feelings to combat that alexithymia. You follow up with, what are your feelings about this test result?
You force them to talk about the emotion, not the anatomy. How does it feel to know the test is clear?
Exactly. You want them to start connecting the emotional dots themselves. A fantastic nursing intervention here is having them keep a symptom journal.
A journal? How does that work?
Tell them to write down every time they feel a massive spike in physical pain, and note what was happening around them at that exact moment. Was their spouse yelling on the phone? Were they worrying about finances? Over time, the journal helps them visually see the connection between their anxiety triggers and their symptom flare-ups. Self-realization is always more powerful than the nurse just lecturing them.
Okay, so we've got the communication and milieu management down. But since we are ultimately treating the underlying emotional distress and anxiety and not the physical illusion, what pharmacological tools do we actually use? What medications do we need to know?
Because the root of somatization is almost always severe underlying anxiety and depression, the frontline pharmacological treatment relies heavily on antidepressants, specifically SSRI selective serotonin reuptake inhibitors.
Wait, if the patient has illness anxiety and they are terrified of getting sick, or if they have terrible stomach pain, why are we giving them a psychiatric antidepressant? Isn't that just going to give them more side effects to fixate on?
It seems counterintuitive until you look at the mechanism. SSRIs increase the amount of serotonin in the synaptic cleft. Serotonin doesn't just regulate mood, it plays a massive role in the descending pain pathways in the spinal cord.
So it's actually working on the pain signals.
Yes. By optimizing serotonin, You are actually helping to repair that broken filter we talked about earlier. You are reducing the visceral hypersensitivity and lowering the generalized anxiety that triggers the symptoms.
What are the specific SSRIs we need to know by name for the exams?
The big three mentioned in the source material are Flextine, which is Prozac, Paroxetine, which is Paxil, and Sertraline, which is Zoloft.
Okay, fluoxetine, paroxetine, sertraline. What are the nursing considerations and side effects we need to monitor for and teach the patient about? Because if we give them a pill that causes a stomachache, they are going to absolutely panic.
And that is exactly why patient education is critical. SSRIs have a very specific side effect profile. You need to monitor for GI upset like nausea and loss of appetite, especially in the first few weeks of treatment.
Explain the mechanism there. Why do SSRIs cause stomach aches?
Because roughly 90% of the body's serotonin receptors are actually located in the gastrointestinal tract, not the brain.
Yeah, 90%.
So when you introduce a medication that alters serotonin levels, it naturally disrupts the GI tract temporarily. Explaining that mechanism to the patient can actually reduce their anxiety. You can tell them, your stomach might feel upset, but that's just the medication interacting with the receptors in your gut. It is not a new disease.
That is a fantastic way to explain it. What other side effects do we monitor for?
They can cause insomnia or somnolence, so sleep patterns need to be tracked. Headaches and dizziness are common early on. And a major one that patients often discontinue the medication for is sexual dysfunction.
That's a huge teaching point. Patients need to know that might happen so they don't just stop taking it abruptly without telling anyone.
Precisely.
Yeah.
And universally across all these SSRIs, you must instruct the patient to avoid alcohol. Alcohol is a central nervous system depressant. It interferes with the efficacy of the medication, can exacerbate the underlying depression, and increase unpredictable side effects.
Now, what about the actual physical pain they're feeling? We already established the golden rule that we avoid narcotic analgesics, but we can't just let them suffer in agony while we wait 4 weeks for the SSRI to kick in, right?
Right, we use non-narcotic options. The standard is NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen or naproxen. It helps reduce the peripheral perception of pain and inflammation without the massive risk of dependence, tolerance, and misuse that comes with opioids.
Aside from pills, what other clinical therapies are effective?
Cognitive behavioral therapy, or CBT, is highly effective. CBT helps the patient identify and alter their erroneous perceptions of threat. It helps them recognize when their brain is catastrophizing a normal bodily sensation. Also, for patients with severe somatic symptom disorder involving chronic pain, a referral to a specialized chronic pain clinic is very useful.
Not to get narcotics, obviously.
No, strictly for pain management techniques. They learn advanced therapies like visual imaging, biofeedback, where they actually learn to consciously control their heart rate and muscle tension, and physical therapy to maintain muscle tone and prevent that disuse syndrome we discussed.
So, as an elite psychiatric mentor, give it to me straight. What does success actually look like for these patients? Are they ever totally cured? Do they wake up one day and never somatize again?
It is vital to manage your expectations, both as a clinician and for the patient. These illnesses are chronic and they are highly recurrent.
Right.
The physiological pathways in their brain are deeply worn in over decades. Success does not usually look like a magical permanent cure. Success looks like harm reduction and improved quality of life.
So success is fewer trips to the ER.
Exactly. Success is fewer visits to primary care providers complaining of mystery illnesses. It is less reliance on multiple medications. It is the ability to use emotion-focused coping instead of immediately developing a migraine when their boss yells at them. And perhaps most importantly, success is improved social and family relationships because the patient is no longer trapped in the sick role, alienating everyone around them.
That is a really grounded, realistic way to look at it. Okay, let's bring this all home. We have covered a massive amount of high-yield ground today. Let's do a quick recap of the 80-20 rule, the 20% of concepts that will give you 80% of the answers for you, the listener, so you are totally prepped for that exam or that next clinical shift.
Rule number 1, the symptoms are real to the patient, they are not conscious, and they are not faking it. Rule number 2, always rule out medical issues first. Check the engine. Rule number 3, limit secondary games. Do not reward the sick role with special privileges or endless attention. Rule number 4, use the communication formula. Validate their distress, but immediately encourage collaborative, independent action. And rule number 5, watch for the distractors, especially the legal requirement to report factitious disorder imposed on another.
Those are the keys to the psychiatric kingdom right there. But before we sign off, there is one final, really provocative thought from the source material that I want to leave you with to mull over. We talked extensively about how culture shapes the expression of these disorders, right? How the ancient Greeks blamed the wandering uterus, and how different regions have Koro or Hwabyung.
Yes, the cultural context.
Well, there is a fascinating modern twist on these ancient disorders. It's called cyberchondria.
Oh, it is a profound, rapidly growing modern problem. With unlimited internet access, people are excessively searching for health information online. But instead of reassuring them, the search algorithm, which is designed to maximize engagement through fear, feeds them worst-case scenarios.
It creates a massive nocebo effect.
Exactly. This algorithmically driven fear actually feeds and massively increases their anxiety, which in turn creates more physical symptoms, which leads to more frantic Googling. It is a vicious digital cycle of physical symptoms and obsession.
It makes you wonder, how will the next generation of nurses handle patients whose primary doctor is an algorithm designed to feed their absolute deepest fears? If the wandering uterus was the cultural expression of the 1800s, maybe the WebMD doom scroll is the ultimate cultural expression of today.
It is an incredible challenge, and it means the psychiatric nursing skills we discussed today, setting firm boundaries, validating without enabling, and teaching real-world coping mechanisms are going to be more important than ever in the digital age.
A huge thank you to you, our listener, for joining us on this deep dive. You now have the high-yield knowledge that will unlock the mysteries of somatic symptom illnesses. Take these concepts, apply them to your next exam, use them to see the reality behind the muddy waters of your next clinical shift, and remember, always check the engine light. Until next time.